we'll hand over to Matthew Campbell-Hill. He's a senior fellow and at the Institute of Clinical Sciences, University of Birmingham. Matthew is an emerging and novel medical technology specialist who has worked with both NICE and the MHRA. Matthew maintains a portfolio of senior roles across many sectors and continues to compete internationally as a member of Team GB. We are delighted he has joined us today to discuss what a medical device is, what you need to consider, and who to consult with before purchasing.
Thank you, Helen and Deborah, and Medstrom, of course, for inviting me to speak to you all today. So I'm here really to talk about the opportunities and pathways in medtech. This is mostly from my experience with working with NICE over about 10 years, and of course the MHRA, the healthcare products regulator. But that also does include what it's like in Europe and a bit in the USA, having worked in those fields. So who am I? I'm a senior fellow at Birmingham University at the medical school there, where I teach and help on emerging medical technologies. Mostly it's the novel technology space, and it could be a bit with design, but really it's about the adoption pathway. Do a bit there in the university teaching the students what that looks like, also with some of the startups there. And most of my work outside that is working in technology in highly regulated spaces, so a lot in the medical sphere, but also in some areas like automation in transport. So let's start at the beginning. A really important part of any design journey is safety, and therefore regulation. It's also the reason that I advise designers to stop as soon as they have an idea in the medical space. So stop as soon as you start. And the same for buyers. So once you've got your basics down, your idea or your requirements, and I really do mean the fundamentals here, stop and consider this question. What is a medical device? Doing this enables you to ensure that you don't end up straying into regulated or safety critical areas which can unnecessarily slow you down, especially if they are not really critical to the clinical outcome or the mission that you're intending to affect. And as a buyer, this is your chance to consider, do I need a medical device? Well, what is a medical device? So this seems really quite easy to understand when it's presented like this. And it is simple. An instrument, apparatus, appliance, software, implant, reagent, material, or other article intended by the manufacturer to be used alone or in conjunction or in combination for human beings. That's in a clinical environment. But what if we remove intended by the manufacturer to be? Suddenly anything can be a medical device. Today, in pretty much every single ward all around the world, I can pretty much guarantee that there's one simple product which is not registered as a medical device, but is being used as a medical device. Anything can then become a medical device. What is that one thing? Well, the calculator. Whether it's a standalone or on a mobile phone, calculators are being used by clinical staff to decide treatments. And it doesn't stop there, because any object or software which is used to alter a patient outcome is a potential medical device. And that means it could be a ruler, it could be a paperclip, you name it. If it is used to affect a patient's outcome, it may become a medical device. So this is the phrase that I use when I teach. Any object or software which is used to alter a patient outcome is a potential medical device. So why do I say this to medical students and doctors? So that they understand how easy it is to get into potentially a sticky situation. They all understand about giving medication off license and that they have to sign a form. They have to really consciously think, is this the right route? So it's only fair that they understand the same about technologies. So is this important? Is it important that they understand the difference between just something just being a technology and then it becoming a medical device? Well, I think yes. It is important. Because let's stick to that calculator for the moment. The early iPhones would cancel errors and continue the calculations if the user was not concentrating on the display. And they don't show workings. So calculators, when we think about this, calculators were only ever intended to be a way to quickly check our own workings. But now we use them as our primary method of calculation. And someone should look up on this is Professor Harold Thimbleby from Swansea University. And in his research, he found that people didn't see the error messages on their calculators, especially on their mobile phones, because they were too busy looking at the actual keypad, especially with mobile phones, because you can't feel where the keys are. So you have to concentrate on that. So if you're pressing a key, or you're pressing a load of keys and there's an error message up, it just won't recognize it. And because they didn't already have an understanding of what to expect on the result, they then did not notice the result was wrong. And that then led to a potential for incorrect treatments. Errors happen and lead to harm because we don't see them happening at the time. That's from Thimbleby. So how does this affect the design and purchasing process? Well, that's why we stopped right at the beginning when we started. Because how does that change, or how does that affect the device design? And this is important if you're a designer or if you're going to be a user, if you're a buyer. Because there's no point having a device which says, or a product that says it can do everything, if it's so difficult in order to do it. So let's just double check whether or not it is actually going to be a medical device. Does it change the outcome of a patient or their treatment? And if so, how does it change it? That next part then leads us into what class of device does it become? And this is where there's a bit more work that you can look up, which will tell you, and we'll go over it a bit now, but it's far better if you look this up in your wider reading, of the types of medical devices. And we won't go into it really in depth, as I said. But as an overview, you have the general medical devices regulations. We have classes 1, 2, 1, 2A, 2B, and 3. And then we also have in vitro diagnostic devices, which are also split into 4 different categories. But it's really easier just to think of sort of those 4 classes in general medical devices, and then the in vitro diagnostic devices as a separate section. So in the general medical device classes, we have class 1, which is low risk, class 2A, which is the low to medium risk, and class 2B, medium to high risk. The class 3 are the really high risk products. So again, we could go into many different things, but I think it's best you just get that. And then we go to the in vitro diagnostics, again, their own separate areas. By having an understanding early on of these different levels, it'll help you to keep in scope, but more importantly, ensures that you never end up in that trap where you have a product being used unregistered and unregulated for a particular medical concern and really becoming quite an intense medical product. When I arrived at the MHRA, this was, as a non-executive director, this was actually just coming into the time where we were starting to look at apps as medical devices. And there had been an explosion of diabetes monitoring apps onto the app stores. Of 44 that we reviewed at the time, I think it was 43 would at some point have certainly caused harm and likely killed someone. And I have no doubt, I don't think anyone in that room when we were reviewing them had any doubt that every single one of those apps was made with good intentions. In fact, quite a few of them were charging very little, if anything at all, for the use of these apps. But they were simply not of sufficient quality, either from the programming or from the clinical understanding. So how do you then as those people? How do you improve the quality of your design of your devices, or the quality of the devices that you're buying in or hoping your staff will use? Well, despite all the talks out there by elite athletes about high performance and winning and telling you that they know the way to build a winning business because they did X, Y, Z at World Championships or the Olympics, as someone who has actually been in both in elite sport and the corporate world there really aren't as many crossovers as those talks may have you believe, except perhaps for one area. And that one area that definitely does cross over is challenge. We have to seek out challenge. We have to challenge our own beliefs and our perceptions about an issue or situation. And in order to do that properly, we have to get others to challenge us. In sport, when I was competing, I retired from elite competition last year. We would in general spend at least 95% of our time rehearsing and being challenged for the 5% of time that we're expected to perform. And at that point, all that challenge we've had, all that rehearsal of challenge and being creative, learning how to respond to challenge, we can then, at performance time, we can roll that out. But in business and the corporate world, or in healthcare and in any other non-performance based role, we actually only tend to spend about 5% of our time seeking challenge and learning because we don't have the time. We spend the 95% performing, doing our jobs. So we need to make certain that we do as much in that 5%, or we can focus and drag out a bit more than perhaps we've done before, to get that challenge in. Now, last year, I designed and launched a product called the Aerosol Shield. It was in response to COVID, and it ended up fitting neatly between the classes that we went through earlier. It wasn't PPE, it wasn't. But we did this. I did it with a few colleagues. We did it as a way to help respond to direct requests from clinicians. Well, we wanted to make sure that we weren't going to be causing issues. So we spent the vast majority of our time actively trying to get negative feedback. We did it during the design, and we did it once we'd launched. And we carried on doing it, and we're still doing it today. In a way, I'm not too bothered. I think the directors, clinicians on our team, and we've got everyone was basically doing it for free and just trying to find a way that we could help. But the feedback that we have all craved has not so much been. It's been great to hear that people are happy using it or feel that it's helped them. That's great. But we want the negative feedback. Why? Well, our core interest is in giving a good product and having a good result and improving that product. There's nothing worse than people not repeat buying your product, or especially, or just having had if you've had a long relationship with that customer, then they just sort of stop and they tail off, purely because they had a bad or a suboptimal experience with your current or last products, but you didn't know. You didn't know that you could have been doing something different for them. So you're just sitting there thinking, well, this is obviously what people want. So we continue to actively chase negative feedback. And I do firmly believe that negative reviews, obviously done in the right way, can be more helpful than good reviews because they make opportunity to get better and improve. Challenge is that opportunity to improve. So actively engage with clinicians. If you're a buyer, if you're a clinician, if you're working in the healthcare space, actively engage with the manufacturers and and for the manufacturers to actually engage with stakeholder groups. And all of you have to come together as much as possible to say, what is it you want? Think of the big questions as well as the small ones, because no question is a stupid question. If it's something that doesn't quite sit with you or you don't understand, then fine. If it's something that took a long time to train people on, well, that's a design feature that could be changed potentially. Think about near misses. Sometimes we don't write down near misses. In fact, at the MHRA, we noted that a very, very small percentage of people reported issues with devices. It's a small percentage of people report issues with pharmaceuticals, but even smaller with devices. In one brilliant quote I had with a clinician that was being reviewed, a product failed during an operation, and afterwards they were asked, are you going to report that? Their response was, no, it happens all the time. So there's no point in me reporting it because it always happens. Well, that's not going to change then. But even if it's user error, so if it's a design, even if it's user error that keeps happening, give feedback on it. We keep doing this. We know it's the wrong thing to do, but we keep doing that. Can that be incorporated? So what does all this drivel I've been spouting on about mean to you if you're the buyer and not the designer? So what's going to do with me? As I said, communicate, feedback the good, the bad, and the ugly. And really importantly, don't just repeat the previous purchase. Challenge each time. Is that exactly what we need, or is that just going to fulfill that rough area of what we want? What is the actual need? Go back to the need every time, rather than just saying, we need this product in there because that's the other ones we've got. Say, okay, tell me what it's for again. Now they reel off the same list as you had originally to get that first product. Great. They reel off a different list. Is it still the right product? Because guess what? If you put in the same input each time, you get the same output. Jim Rohn was a motivational speaker, but he was also built up several businesses over his life and failed several times and built up big ones each time. A lot in healthcare. He has a lot to say about failure and how failure is good if you do that feedback loop and come back onto it. So that recognizing that it goes both ways is really important, because if you want better products, better services, better outcomes, or if something doesn't do what it could, we need to tell each other. We need to not fall into the trap of making the same purchase over and over just because it's comfortable. We need to engage with the users of the kit, and we need to note all feedback, even if we don't think it's relevant at the time. Sometimes you may even find that what you bought does do everything you need, but again, as I said, your staff don't understand how to do it. So tell the company, get the training in, get the value you've already paid for. And if you find you keep being disappointed by your technology purchases and it's not just one product or one company, then the message is already there. You need to change your approach to get a better outcome. If you don't, the same input gives you the same output. So positively engage with the manufacturers and their sales staff. Tell them your needs and give them feedback, even that minute stuff. And then ask them to follow up with you, back to you and say, this is what we're going to do about it, or we don't think we can do that. That's fine. But whichever side of the conversation you're on, understand this. Improving and future-proofing products requires this interaction. To be heightened, to encourage procurement teams and clinical engineering and other stakeholders to encourage other factors when writing a product spec. This has really got to start before you do your product specification, your needs requirement, your needs journey. Do the work first with the clinicians, with the teams, with the stakeholder groups. What are the specifications I'm expecting? What are the specifications they're expecting? Take that to the company, whether you're on a design journey with them or whether you're just on a purchasing journey. Get them to review that and tell you, are those the specifications, are those the outcomes they're expecting? Because that's the really important part, that when it does what you expected. If it does more, that's fine. but it's got to do what you expect and what you need it to do. This leads into the idea that I also talk about probably far too much if you speak to some of my students. But every conversation is a sales conversation. And that sounds very sort of 1980s American pushing sales, isn't it? From all the films and the old documentaries. But it really is quite, at a basic level, it is that. Because what do we have? At the heart of every single conversation, we have three basic issues. We have a problem. So we have something that someone raises. It starts that. We then prove that we understand that problem. And that may back in circles. Don't understand the problem. Do I understand it now? No, you don't. Do I understand it now? No, you don't. So we get that bit. And then we provide that solution. So we've got a problem, we prove we understand it, and we prove that our solution understands that problem. So all we've got to do now is agree the cost. Now, it may be that my solution to your problem may understand it, but it may just be too costly, whether that's time or actual cash, or there are other costs. It may be staff layoffs, it may be a change in procedures that we don't want to do, and we'd see that as a cost. But it really is every single conversation. So what could those things look like? This doesn't work. It's too heavy to use. Okay. This is the other person talking. You want something that is lighter, and that is too heavy. Okay, that will mean we would change the materials. Yes, great. It will take us more months, and it will cost this much more. So what do we have? We have our problem. This doesn't work, it's too heavy. Great. We have an understanding and a solution. I see, I understand, we get this. Just going to check that that is in agreement with you. Yes, great. And now we've got that cost. And then we just got to agree on that. So having started with a problem, we can just keep going through the cycle of these stages. And in case you think I'm wrong, that pretty much every conversation is a sales conversation, my 7-year-old this morning, Dad, can I have chocolate spread for breakfast? I really want it. Yes, you really like chocolate spread, but no, chocolate spread won't fill you up. You need to have your cereal as normal. Oh, but I really want it. And you can all picture those faces. If you've got kids of that sort of age, you know the faces they're pulling. Yes, but so my response, if you have cereal now, you don't cause a fuss because we've got to get to school, and you're good at school today. It'd be terrible to load him up with chocolate before we went into his teacher's, poor thing. Then after school, you can have chocolate spread after school on a sandwich. His response, pretty much, yay! You know, we don't do that enough, do we, as adults? Yay! So what was his problem? His problem was, I want chocolate. Chocolate, I want it. I had to prove my understanding, my solution. I recognize that you want chocolate. I know what chocolate, and more importantly, I know the effect that it has on you as a child, both the positives and the negatives. So I confirmed that I understood the problem. And then what was the cost? Because I've started saying, I can say, you can do this. Here's my solution for you. I've confirmed, here's a solution. He needed to eat his breakfast and go to school first and be good. And then we just had to say, was that a deal? Can we make that? Can we close that deal? His yay, not written, not signed, but I took that as a pretty firm, that's going to be a yes. So we openly communicated, and this is what we do in all levels. It's pretty much the same conversation. I wish it was possibly, I don't know if it's easier with a 7-year-old or with other adults, but openly communicated, gave our feedback, told each other the problems, and listened carefully to be sure that we understood each other's issues. And to do that, whether I'm talking with a 7-year-old about chocolate or whether colleagues and peers of all age groups, we use simple, clear language. And if they don't, ask them to. The simple, clear language that stays the same throughout stops confusion and makes sure that everyone's on the same page. Thank you very much.